What if the warning your body has been sending you for months was not in your chest, not in your head, and not in your heart, but in your legs? Most people think of a stroke as something that happens suddenly. One moment you are fine, the next you are on the floor. And while that sudden onset is real, what the research increasingly shows is that for the majority of stroke survivors, the body was broadcasting signals weeks, sometimes months in advance. Signals that were felt, noticed, dismissed, and forgotten. Signals that, had they been recognized for what they were, could have changed everything that came after. I have worked in vascular medicine and senior health for over 2 decades, and the pattern I see again and again is not a lack of symptoms before a stroke. It is a lack of understanding about what those symptoms mean. People feel something in their legs, and they attribute it to age, to arthritis, to sleeping in the wrong position, to the weather. They do not think, this is my cardiovascular system asking for help. Today I want to change that, because the 7 warning signs I'm going to walk you through are not rare. They are not subtle. They are things that millions of people over 70 are experiencing right now, in their bedrooms, in their kitchens, walking to the mailbox, and writing off as nothing. And for a significant number of those people, those sensations are not nothing. They are the earliest, most actionable warning window that medicine has ever identified for stroke prevention. If you have felt any of these in the last 3 to 6 months, stay with me, because understanding what you are about to hear could be the most important thing you do this year. And before we get into this, if this is the kind of health information that matters to you, hit the subscribe button and drop a 1 in the comments if you have noticed any unusual sensations in your legs recently. I want to know how many of you this is reaching. There is a very specific kind of cold that has nothing to do with the temperature in the room. It is a coldness that lives inside the leg, in the tissue, in the muscle, and it does not change when you put on warmer socks or move to a warmer room. You can hold a heating pad against that leg and the cold persists, because it is not a surface temperature issue. It is a circulation issue. When one leg is noticeably colder than the other, not both legs, not a general chill, but one leg distinctly colder, this is a sign of asymmetric arterial blood flow. Blood is reaching one leg less efficiently than the other. In most cases, this is caused by a developing arterial blockage in the vessels supplying that limb. Atherosclerosis, the buildup of plaque inside artery walls, does not happen uniformly across the body. It concentrates in certain vessels first. Here is the critical connection to stroke. The same atherosclerotic process building up in the arteries of your leg is almost certainly building up in the arteries supplying your brain. These are not separate problems. They are the same systemic problem expressing itself in the most accessible location, your leg, before it reaches the most catastrophic location, which is your brain. A study published in the journal Stroke found that individuals diagnosed with peripheral artery disease, which is the clinical name for what that one cold leg sensation often represents, had a stroke risk 2 to 3 times higher than age-matched individuals without it. Not slightly elevated, 2 to 3 times. If you are experiencing persistent unilateral leg coldness, meaning one leg consistently colder than the other over weeks or months, the test you need is an ankle brachial index, or ABI. This is a simple, painless, non-invasive test done at your doctor's office that compares blood pressure in your ankle to blood pressure in your arm. An abnormal result is one of the clearest early markers of systemic vascular disease. Request it by name. This one has a name in medicine. It is called claudication, and it is one of the most underreported, most dismissed symptoms in adults over 70, partly because the relief is so reliable. You walk a block, your calf cramps, you stop. Within a minute or two, it is gone. You walk again, it cramps again, you stop again, it goes away. Because the rest reliably makes it stop, people do not classify this as a medical problem. They classify it as a limitation. They start walking shorter distances. They take breaks they did not used to take. They tell themselves they are just getting older. And the cramping, which is their leg muscles screaming for oxygen because arterial flow is restricted, continues happening every single day while the underlying arterial disease progresses untreated. Claudication is not a muscle problem. It is not a joint problem. It is not age. It is a vascular event that repeats itself every time you walk, because every time you walk, your leg muscles require more oxygen than your narrowed arteries can deliver. The moment you rest, demand drops, the pain resolves, and nothing has been addressed. The connection to stroke here is direct and well documented. Claudication is a textbook presentation of peripheral artery disease, which in turn is one of the strongest independent predictors of major cardiovascular events, including ischemic stroke. A major meta-analysis covering over 40,000 patients found that individuals with symptomatic PAD had a stroke rate approximately 40% higher per year than the general population of the same age. When you next see your physician, describe this symptom exactly as it presents: pain or cramping in the calves that comes on with walking at a consistent distance and resolves within 1 to 2 minutes of rest. That description is a clinical flag. It should trigger a vascular workup, not a prescription for a muscle relaxant. Your skin is the most visible organ in your body, and the skin on your lower legs, from just below the knee down to the ankle, is one of the most reliable windows into the health of your peripheral vascular system. What you are looking for here is a specific cluster of changes that often appear gradually and are often attributed to dry skin, age spots, or sun damage. But they are not those things. They are the result of chronic vascular insufficiency, blood either struggling to get down into the lower leg or struggling to return from it. The first change is a rust or brownish discoloration, often described as staining that appears on the lower shin and ankle. This is called hemosiderin staining, and it occurs when red blood cells leak out of chronically distended capillaries under pressure and break down in the tissue, releasing iron that deposits in the skin as a dark pigment. It is painless, it is permanent, and it is a direct marker of venous hypertension, elevated pressure in the leg veins caused by valves that no longer close properly. The second change is a thinning, shiny, almost waxy appearance of the skin on the lower leg, particularly around the ankle. This indicates that the tissue beneath the skin is being remodeled by chronic inflammation from poor circulation. The third change is hair loss on the lower legs and the tops of the feet, not the upper leg, not the thigh, but specifically the lower extremity. This occurs because the hair follicles, which are highly metabolically active and require consistent arterial blood supply, begin to die off in areas of chronic ischemia, reduced blood flow. Any one of these changes deserves mention to your physician. All three together is a vascular emergency in slow motion. These are not cosmetic changes. They are tissue-level evidence of a circulation problem that has been building for long enough to visibly alter your skin, and a circulation problem of that duration and severity is exactly the environment in which stroke risk accumulates. There is a specific quality to this symptom that distinguishes it from ordinary tiredness. It is not a tiredness that comes from activity. It is a heaviness that builds from simply existing. You wake up in the morning and your legs feel acceptable. By early afternoon, they feel thick. By evening, they feel like they are filled with something that should not be there. You sit down and elevate them, and within an hour, they feel somewhat better. You go to bed, sleep through the night in a horizontal position, and wake up to legs that feel acceptable again. This cycle, heaviness building through the day, improving with elevation, resetting overnight, is the textbook presentation of chronic venous insufficiency combined with diminished arterial return. The horizontal position during sleep allows gravity to stop working against your compromised venous valves. The vertical position during the day means every hour is another hour of pooling blood fighting inadequate return pressure. The cardiovascular implications are significant. Chronic venous insufficiency creates a prolonged state of local inflammation in the leg tissue. That inflammation releases systemic inflammatory markers, C-reactive protein, fibrinogen, interleukin-6 DAS that enter the bloodstream and increase the stickiness of blood platelets. Stickier platelets form clots more readily, and clots, whether they form in the deep veins of the leg or in the arteries of the brain, are the direct mechanical cause of the majority of ischemic strokes. This is not a coincidence of pathology, it is a cascade. Leg vein dysfunction leads to systemic inflammation, leads to a hypercoagulable state, leads to elevated clot risk, leads to stroke. The early warning is in the legs. The catastrophic endpoint is in the brain. If you experience this pattern of daily progressive leg heaviness, your physician should order a duplex ultrasound of your lower extremity veins. This is a painless, non-invasive imaging test that evaluates both the structure of your veins and the direction and velocity of blood flow within them. It can identify venous insufficiency, deep vein thrombosis, and early thrombotic disease before any of those conditions has produced an acute event. Bilateral ankle swelling, both ankles swelling equally, is a common and well-recognized sign of systemic conditions, including heart failure, kidney disease, and low protein levels, and it is something most physicians are attuned to asking about. What is less commonly discussed, and what carries a more urgent vascular significance, is unilateral swelling. One ankle, one foot, one calf, noticeably larger than the corresponding limb on the other side. Asymmetric swelling is the cardinal presentation of deep vein thrombosis, a blood clot forming inside the deep veins of the leg. DVT affects approximately 900,000 Americans per year. It is most common in adults over 65, and its relationship to stroke is among the most direct and dangerous in all of vascular medicine. Here is the mechanism. A clot forming in the deep veins of the calf or thigh does not stay there. It grows. And when a portion of that clot breaks off, which is called embolization, it travels through the venous system, through the right side of the heart, and into the pulmonary circulation. This is a pulmonary embolism, and it is acutely life-threatening on its own. But in adults over 70, there is an additional risk. Approximately 25% of adults have a cardiac structural variation called a patent foramen oval, a small opening in the wall between the upper chambers of the heart that typically closes at birth but remains open in roughly 1 in 4 people. Through this opening, a clot from a leg, DVT, can cross directly from the venous circulation into the arterial circulation and travel to the brain. This is called a paradoxical embolism, and it is one of the most common causes of cryptogenic stroke, strokes where the cause is initially unclear, in adults over 65. One swollen ankle that you have had for 2 weeks and attributed to bumping it or wearing tight shoes or standing too long may be a DVT, and that DVT may be one dislodgement away from your brain. If you have unexplained unilateral ankle or leg swelling that has persisted for more than a week, do not wait for your next scheduled appointment. Call your physician and describe it specifically as one-sided leg swelling of unknown cause. This should trigger same-day or next-day evaluation. There is a version of tingling in the feet that is positional. You cross your legs, compress a nerve, and your foot goes to sleep. You shift your weight, the pressure releases, and within a minute or two, the sensation is gone. This is normal. This is not what we are talking about. What we are talking about is a tingling or numbness that is persistent. That is present when you wake up in the morning. That does not correlate with any particular position. That affects both feet simultaneously, or that affects one foot consistently without any obvious mechanical explanation. That has been present for weeks or months and has not resolved. Persistent lower extremity neuropathic symptoms in adults over 70 can arise from several sources, 2 of which are directly connected to stroke risk. The first is diabetic peripheral neuropathy in individuals with type 2 diabetes or prediabetes, which damages the small nerve fibers in the feet and lower legs. Diabetes is itself one of the strongest independent risk factors for ischemic stroke. People with type 2 diabetes have a stroke risk 2 to 4 times higher than non-diabetic individuals. Peripheral neuropathy appearing in the feet is often the most visible early sign of the systemic vascular damage that diabetes produces, long before a stroke occurs. The second source is cerebrovascular small vessel disease, tiny blockages accumulating in the small perforating arteries that supply the deep white matter of the brain. In some individuals, small vessel disease presents not with the dramatic symptoms we associate with major stroke, but with gradual changes to sensation and fine motor control in the extremities, including persistent tingling and numbness in the feet, as the first detectable sign. A study published in Neurology found that individuals with lower extremity neuropathy of vascular origin had a significantly higher incidence of white matter lesions on MRI, the structural brain changes that predict future stroke, or than age-matched controls without neuropathy. Persistent foot tingling deserves evaluation. The blood panel should include fasting glucose and HbA1c to evaluate diabetes status. If vascular neuropathy is suspected, your physician may refer you for nerve conduction studies or for brain MRI to assess for white matter changes. Restless leg syndrome is one of the most common neurological conditions in adults over 70, affecting an estimated 10 to 15% of the elderly population. It is characterized by an irresistible urge to move the legs, most often in the evening or at night, accompanied by uncomfortable sensations that most people describe as crawling, pulling, aching, or electric. Moving the legs temporarily relieves the sensation. Stopping the movement allows the sensation to return. Most people who experience this are told, if they mention it at all, that it is a sleep disorder and that the primary concern is sleep quality. Prescription medications like ropinirole, which is sold as Requip by GlaxoSmithKline and available through any pharmacy including CVS and Walgreens with a prescription, and pramipexole, sold as Mirapex by Boehringer Ingelheim, are commonly prescribed. And while those medications address the symptom, they do not address the underlying vascular component that research has increasingly implicated as a driver of RLS in older adults. A 2019 synthesis published in Sleep Medicine Reviews found that restless leg syndrome was independently associated with a 30 to 40% increase in the risk of cardiovascular events, including stroke in adults over 65. The proposed mechanism involves chronic sleep disruption, elevating sympathetic nervous system activity, increasing blood pressure variability overnight, and triggering systemic inflammation, all of which are independent stroke risk factors that compound over months and years. But there is an additional mechanism specific to older adults. Restless leg syndrome in the elderly is frequently associated with dopamine system dysfunction and iron metabolism dysregulation in the brain, changes that overlap with the early neurological disruptions seen in individuals at elevated risk for vascular dementia and cerebrovascular disease. The critical point is not to dismiss RLS as a nuisance. If you have been experiencing it for months and it has not been evaluated for its cardiovascular implications, not just its sleep implications, that evaluation is overdue. A full iron panel, a ferritin level, blood pressure monitoring, including nighttime blood pressure, and a cardiovascular risk assessment should all be part of the workup for persistent RLS in anyone over 70. Now take a step back with me and look at what connects all 7 of these warning signs. Every single one of them is peripheral. Every single one of them shows up in the legs, in the feet, in the skin, in the sensation of the lower body, not in the chest, not in the head, not in the throat. And every single one of them is connected through a documented biological pathway to the cardiovascular and neurological processes that produce stroke. This is not a coincidence. This is anatomy. The vascular system that supplies your brain and the vascular system that supplies your legs share the same origin, operate under the same physiological pressures, and fail by the same mechanisms. Atherosclerosis does not respect anatomical borders. Inflammation circulates systemically. Clots travel. The leg is the early warning system for the brain precisely because it is farther from the heart, less well perfused, and more sensitive to vascular compromise, which means it shows the signs of systemic vascular disease first, often by months. The medical community has known this for a long time. The public has not been told clearly enough. What I want you to do with this information is specific. Take a piece of paper and write down which of these 7 signs you have experienced in the last 6 months. Not a vague maybe, a genuine yes or a genuine no for each one. One-sided leg coldness, calf cramping with walking that stops when you rest. Skin changes on the lower leg, including darkening or hair loss. Progressive daily leg heaviness that improves when you elevate. One ankle swelling more than the other. Persistent tingling or numbness in the feet. Restless legs at night that have persisted for months. If you have two or more of these, you need a vascular risk assessment, not eventually, not at your next annual physical. Soon, this week if possible. The assessment includes an ankle brachial index test, a lower extremity duplex ultrasound, and a full cardiovascular risk panel including C-reactive protein, fibrinogen, fasting lipid panel, HbA1c, and 24-hour blood pressure monitoring. The window between early vascular warning signs and a stroke is not infinite, but it is real, it is measurable, and it is the window in which everything can still be changed. Tell me in the comments, which of these 7 signs do you recognize? How long have you had it? And has any doctor ever connected what you feel in your legs to your stroke risk? Your answer might be exactly what another person watching this needed to read today.